So the next category of drugs that can be used, that are usually used to treat angina pectoris, is the calcium channel blockers, such as nifedipine, diltiazem, verapamil, and the other drugs. So most of these calcium channel blockers have a half-life of about 3 to 6 hours. So this is the list of commonly used calcium channel blockers, and with the starting dose and the maximum dose recommended. So we have amlodipine, felodipine, isradipine, lacidipine, darcanidipine, icardipine, nifedipine. Okay, and then we have nifedipine slow release. And then after memorizing the pins, okay, amlodipine, all that, then we have to memorize diltiazem, because diltiazem is also quite important. So we can't just ignore this drug, diltiazem, and also we cannot ignore verapamil. So both are important in management of certain diseases of the heart. So verapamil, so diltiazem, verapamil slow release, these are all used. So these are basically cardiovascular drugs, mainly. So mechanism of action of calcium channel blockers, they block voltage-gated L-type calcium channels. Okay, they block the voltage-gated L-type calcium channels. Okay. So usually we tend not to remember all this. We just remember it blocks calcium channels. Okay, that's the most important, most fundamental and easy part to remember. And if one can remember more than that, that's better. So by reducing calcium influx during action potential, okay, so it reduces calcium influx. So during action potential, we are expecting calcium to go in. But when we block the L-type calcium channels, okay, so when we block this with the calcium blockers, so there will be reduced calcium going in during the action potential. So we don't get so much of calcium going in. So this will reduce calcium concentration inside, and also the muscle contractility. It reduces the muscle contractility. However, these calcium channel blockers do not block the calcium-dependent neurotransmission or hormone release. Okay, so they do not block calcium-dependent neurotransmission or hormone release. They only block, they only reduce muscle contractility after reducing intracellular calcium concentration. So IC is intracellular. Okay, IC is intracellular, AP is action potential. So the effects of calcium channel blockers: it relaxes the blood vessels, obviously. And then for diltiazem and verapamil, it reduces the rate and contractility of the heart. And it also blocks the calcium-dependent conduction in the AV node, atrioventricular node. And this will allow, this is the reason why these drugs are used to treat atrioventricular nodal arrhythmias, okay? AV nodal arrhythmias. So we can use diltiazem and verapamil to treat AV nodal arrhythmias. Nifedipine, it evokes a greater vasodilatation, so it causes a greater vasodilatation. And this will lead to a sympathetic reflex, okay, that prevents the lowering of heart rate, and may, instead of lowering heart rate, may increase the heart rate, okay, may increase the heart rate. So this is not desirable for patients who are having a heart problem, of course. Okay, so when the perfusion in the heart is compromised, you don't want to increase the heart rate. But generally speaking, all calcium channel blockers reduce the blood pressure and reduce the double product in angina patients. So in short, this is what the calcium channel blockers do. So what are the clinical use? What are the indications for giving calcium channel blockers? So it's for prophylactic therapy in two types of angina, mainly effort angina and also vasospastic angina. Nifedipine is used to abort acute angina, and calcium channel blockers are useful when combined with nitrates for severe atherosclerotic angina. Okay, for severe atherosclerotic angina, it's useful to combine the calcium channel blockers with nitrates. And also, obviously, they are used for hypertension, supraventricular tachycardia, for migraine, preterm labor. So preterm labor means labor, they go into baby delivering mode before they are supposed to. Okay, most of the kids before 36 weeks usually. Okay, considered before 36 weeks is called preterm labor. And then we have stroke, and then Raynaud's phenomenon. Nimodipine, okay, is only used for hemorrhagic stroke. Okay, hemorrhagic stroke, and not for the other kind of stroke, the thrombotic stroke. Okay, so there are two types of stroke. Okay, cerebrovascular accidents, also known as stroke. We have the hemorrhagic and also the thrombotic. Okay, the one where you have bleeding, and the other one you have blockage. Okay, so both conditions can compromise the blood supply to the heart. Okay, you have to the brain. Okay, both will compromise the blood supply to the brain. So therefore, we cannot use nimodipine. In the other kind of stroke, you only use nimodipine you can use it in hemorrhagic stroke. So adverse effects of the calcium channel blockers: constipation. Can remember this. So you block calcium from coming in, so that will lead to constipation, less contraction. So your muscles cannot contract. So when you cannot contract, you don't allow the delivery of food through the intestine. Okay, because it's not contracting. Okay, because of lack of calcium that goes into the channel. Pretibial edema. Okay, pretibial, tibia, and then edema, nausea, flushing. Okay, this is flushing. So they get also giddiness. They feel dizzy. They can develop dizziness because of the vasodilatation, obviously. And the toxicity are more common with verapamil than the dihydropyridines. Okay, the dihydropyridines such as amlodipine, nifedipine, etc. Next category of drugs is the beta blockers. So beta blockers, they reduce the heart rate, reduce the cardiac force, and also they can reduce the blood pressure. Okay, because reduction in heart rate itself can lead to reduction in the blood pressure. So this is only used as a prophylaxis. Okay, beta blockers, they are not used during the acute attack. Okay, so beta blockers is not a life-saving drug during the acute attack. And it is effective against exercise-induced angina, but not the vasospastic type. Okay, it's useful against the exercise-induced, but not the vasospastic kind of angina. And beta blockers, it's useful to combine it with nitrates, as it counters the compensatory effects caused by nitrates. Okay, because we know nitrates causes increase in heart rate, causes increase in cardiac force due to the sympathetic effect, compensate as a compensation by the body. So if we can use the beta blockers, then we can counteract the effect of increase in heart rate and increase in cardiac force. Okay, so it will reduce or normalize the heart rate and reduce or normalize the cardiac force when we give it together with the nitrates. Contraindications, very important. Okay, some are just part of we could say common sense, and some are it's a bit of thinking. So asthma, okay, because it causes bronchoconstriction. Similarly, COPD, okay, chronic obstructive pulmonary disease. Of course, if you don't use this, causes bronchoconstriction and then bradycardia. So when you have a low heart rate, you don't want to block the heart further and cause a further reduction in stoppage of the heart. Left ventricular heart failure, okay, and also you don't want to use it in coronary artery stenosis. So these are the commonly used beta blockers. Some of the commonly used beta blockers: esputalol, atenolol, okay, betoxolol, bisoprolol, carvedilol, labetalol, metoprolol, propranolol. So this is just brief recap of the beta blockers. You can revise beta blockers from the lectures on antihypertensives and other lectures. So consider studying the effects of nitrates alone, or consider the differences, okay, when nitrates are given alone, or when given with beta blockers, or calcium channel blockers in angina pectoris. Okay, this is something for you, like a homework for you to go back and study. And then we have the non-pharmacologic therapy of angina pectoris. Okay, this will not be tested in the exam for this subject. As shown previously in the earlier slides, we have coronary artery bypass grafting, and then we have angioplasty. Okay, angioplasty whereby you insert a catheter. Okay, I think that's all for the angina pectoris mini lecture. Try to revise the basics to understand the cardiovascular physiology and pathology before coming to this mini lecture. Okay, that's all. Thank you.